Good morning and welcome to the Affordable Care Act, everything you'd like to know about. We're going to try today to cover a lot of different parts of the Affordable Care Act and the impact it's going to have on individuals, small groups, and large groups today. So we're going to touch on lots of different areas, which I'm sure will generate lots of different questions. And I would ask that if you can, try to hold your questions towards the end so we can get through a lot of the presentation first. And then we'll be here as long as we need to be here to answer everybody's questions. First, I'd like to introduce myself. I'm Roy Lyons. I work for a company called Marsh, and we serve as the New York City Bar Association sponsored insurance program administrator on their health insurance, professional liability, and many other programs. With me today, Dan CORR. Dan is a principal over at Mercer. Mercer is the largest employee benefits consulting company in the country. And also Greg TROTTA. Greg is the consultant with UnitedHealthcare, who actively works with us on the City Bar sponsored medical program, as well as many other different programs with UnitedHealthcare. Today, as I said, we're going to give you a fairly good high-level overview of the Affordable Care Act. We're going to talk a little bit about the individual mandate, essential health benefits, and grandfathered programs. We're going to talk about the individual exchange and the small group exchange, which is called the SHOP exchange. And then we're going to move into the large employer world, the employer mandate, and give you a glimpse into some of the activity in the private exchanges that large employers are going for. And then we'll open it up for questions after that. As many of you probably know, the Affordable Care Act was signed into law by President Obama on March 23, 2010. And that really triggered one of the most transformational changes in health care since Medicare. So far, it has survived a Supreme Court challenge, a presidential election, and repeated congressional attempts to repeal or defund the act. And at 40, and I think it's already 41 since I put this together, there have been more and more votes trying to diffuse the Affordable Care Act, but it looks like all those have failed and will continue to do that. 6 months after March 23, we started seeing changes in health plan administration and design as a result of ACA, and everybody's eagerly waiting October 1st. As a matter of fact, when we put this or slotted this date for this presentation, we thought September was a pretty sure thing to have everything we needed to announce to everybody on October 1. Well, whenever you have the government involved, I think things don't go according to plan. And here we are, September 19th, and we're still waiting for plan designs, in many cases around the country, rates, and carriers to announce the plans that they will be offering. So we don't have as much detail as we thought we would have for you today. And the one thing for sure that we know is that every day brings a new change. And we have deadlines coming up, and we see deadlines going by the wayside and being postponed and delayed. The employer mandate, which was supposed to be effective this January, has been pushed off to January of 2015. But we do know that the exchanges officially are slotted to open October 1. That is the start of the open enrollment. Coverage effective dates don't happen until January 1. So really that's the key date. And I think you'll see around the country some exchanges opening their doors on October 1 and others delaying until maybe November. And I was at a meeting in Chicago this week where rumor had it that there was a 95% chance that the federal exchanges, federally run exchanges throughout the country, probably wouldn't be taking electronic applications until November 1st. So it looks like that announcement may be coming out in the next few days. But one thing that is happening October 1, there's an employer notice requirement, which we'll get into a little later. That'll be definitely happening October 1. And then the federal budget starts again on October 1. We're hearing that there's a motion to defund health care reform again in order to get the new budget passed. So we'll see what happens there. But for purposes of today's meeting, we're going to focus on a lot of the changes that are being implemented for January 1, 2014 and forward. Just to summarize on a broad brush basis, number one, probably the most pervasive change is going to be the individual mandate, and that's going to require that individuals have and maintain coverage that provides minimum essential coverage to individuals. If they don't have that, penalties will start taking place in 2014, and that'll be the greater of $95 per individual, or 3 per family, or to a maximum of 1% of the family income. In 2015, that kicks up to $325 per individual, or 2% of family income. And in 2016, it's the greater of $695 per individual, or 2.5% of family income. So the penalty isn't really steep in that first year in 2014, but it does grow pretty quickly. Insurers will no longer be able to deny coverage for anybody, so they must accept everyone that applies for coverage on January 1, 2014, and they will no longer be able to impose pre-existing condition limitations on policies. Now, in New York, they've had to accept individuals on a guaranteed basis, but did have the pre-existing condition limitation ability, and that goes away on January 1. And in another major change for 2014 is the creation of the exchanges. And you'll have the individual exchange or the small business exchange called the shop exchange. In New York, they've adopted the name New York State of Health, and that's the name of the exchange here. And that's for employer units of 2 to 50 employees. In January 1, 2016, that will expand to 2 to 100 employees. Tax credits and benefit subsidies will be available to individuals on the exchange only. So if you buy an individual policy off the exchange, you won't have access to those credits. But if you do buy it through the exchange and your income is below certain levels, you'll qualify to get a subsidy in terms of a tax credit. And depending upon your level of income, you'll also have a benefit subsidy, which will offset some of your co-payments that you have under your plan. Essential benefits, individual and small group plans will now have to provide certain key essential benefit coverage in every plan. So that will be one change that will occur as well. Out-of-pocket expenses no longer will be a big variable among plans. The maximum for co-pays, co-insurance, and deductibles for in-network services, $6,350 for an individual, $12,700 for a family. Those numbers sound familiar. It's because those are the limitations on a health savings account, high deductible health plan, and that's what the legislation is geared to. Some plans have separate out-of-pocket maximums for prescription drug coverage as well as the medical components, and in 2014, those will both be allowed, but in 2015, it'll have to be consolidated into one. You've probably heard a little bit about metal tier levels now. Each state will have a base plan that will be the model, and then off of that, you have 4 tiers of coverage: platinum, gold, silver, and bronze. And then each of those plan designs in the exchange and off the exchange will have to meet the level of benefits, so that on a platinum plan, 90% of the plan benefits have to be paid by the plan, 10% would be paid by the insured for an average population. So platinum will be your richest plan. Bronze plans, 60% of the benefits paid out through the plan would be through the plan, and then 40% would be paid by the individual. And of course, your pricing would be adjusted accordingly. Small group risk adjustment factors, not a factor in New York, but other states would charge a base rate for small employers, say a 1.0 rate for a group of a certain size, and then if it was a larger small group, it would be a 0.9. If it was a smaller small group, it'd be a 1.1. All that's gone. Everybody pays the same rate going forward. Small group plan deductibles. Today you see a lot of higher deductible plans out there. According to the law, when it was passed, $2,000 would be the maximum individual deductible, $4,000 per family. And in order to meet the actuarial values that were established by the base plan, a lot of carriers are unable to meet that $2,000, $4,000 limitation. So there have been guidelines issued to permit carriers to exceed those deductibles, and in order to meet the gold, silver, platinum thresholds on those plans. So relief has been provided on that. Premium under the law is allowed to vary by geography. It's allowed to vary by family composition, individual only, one dependent, two or more dependents. In some states outside of New York, they're also able to vary the rate by age. And in New York, it's all community rated, so everybody pays the same. But this will be an interesting thing in some states, because usually you have a spread between the youngest age and the oldest age, anywhere from a 5 or 6 to 1 ratio. Those will be collapsed. So you'll see rates increasing dramatically for younger people and stabilizing or coming down a little bit for older people. And then tobacco usage. They can surcharge tobacco use by 50% if they choose to do that in a particular state, not a factor in New York. For small employers, the maximum waiting time for benefits to begin, 90 days. So everyone has to change their plans accordingly. There'll be many new taxes and fees that health plans will have to pay in order to support the ACA, and a lot of those will be passed on to the consumer in their premium, which is no surprise there. Catastrophic plans. They'll also be offering catastrophic plans to individuals under age 30, and also those who can't afford to meet or to purchase the other tiered programs, the other metal tiered programs. There'll be a very high deductible plan out there that individuals will be able to use to satisfy the individual mandate requirement. And as I mentioned before, political activity is always rampant here. These are just some of the bills that have been introduced over the last few months to alter the Affordable Care Act. One was introduced just last week to prohibit distribution of the premium tax credits until HHS has come up with a way to actually verify household income and other qualifications that allow an individual to qualify for subsidies. Because right now people are going to have to complete an attestation that their income is X and they don't have employer coverage, et cetera. And that's it. There's not going to be any significant check on it until they wind up paying their taxes in 2015 for 2014. Another requirement was or another piece of legislation for the pay or play, where it's set at 50 employees today, to move that up to 100 employees. Another piece of legislation has been introduced to change full-time hours from 30 hours to 40 hours. Another one would delay the pay or play penalty till 2016. And then another piece of legislation was introduced to repeal the $2,000, $4,000 limit on small employer deductibles. But as I mentioned earlier, that's really not going to be a factor since they've already provided some relief in that area. I'm going to talk a little bit about the individual mandate, essential health benefits, and grandfather plans right now. Under the law, individuals must have and maintain health coverage that provides minimum essential coverage. And there are a couple of ways you can do that. Buying an individual policy in the individual marketplace. If you have an employer plan that's affordable and meets the minimum value requirements. If you purchase something through the state health exchange. If you're on a government program like Medicaid, or if you're in a grandfathered plan. And a grandfathered plan we'll get into in a moment. The only exceptions really are for religious purposes. You can get accepted from the mandate. If you don't make enough to file an income tax return, you can get accepted. If you're incarcerated, you don't have to comply with the mandate. I'm not recommending that as a way to go to get out of purchasing health insurance, but if you're undocumented, you don't have to. If you're a Native American, and you're also allowed to have a gap of 3 months during the year where you can be without coverage. All non-grandfathered plans offered in the individual and small group marketplace, whether it's on exchange or off exchange, must provide essential health benefits. And these 10 different health benefits all have to be components of your health plan. And generally, most of them are, although maternity in the individual marketplace was in some plans, was not in other plans. And one of the new things that they've introduced is pediatric services. Pediatric oral and vision care now have to be part of an individual or small group policy. As I mentioned earlier, part of that overall package is the individual out-of-pocket for somebody in 2014 will be $6,350, $12,700 family-wise, and again, those are just the in-network limitations. They can't exceed that. Out-of-network, those can all be higher as well. And then everybody's got to have an actuarial value, each plan, that corresponds to platinum, gold, silver, or bronze. And again, most of this structure is about the silver plan level. That's what you'll see a lot of talk about in the exchanges. 70% of the plan, 70% of the benefits that will be paid by the plan, 30% by the individual. Now, grandfathered plans, if you recall back when this was passed in 2010, President Obama said, if you like your plan, you'll be able to keep it. So that's what we mean by grandfathered plans. Anything in effect prior to March 23, 2010, as long as it has not undergone dramatic change, it will be able to be continued without having to meet some of the requirements under ACA. A plan will lose its grandfathered status, though, if it makes some of these types of changes. One is if it's an employer plan and the employer decreases their contribution by 5% or more, then it's no longer a grandfathered plan. If they impose any kind of dollar value benefits below a certain amount, it would lose it. If they increase the copay by more than $5, they'll lose grandfathered status. Increasing the deductible by more than 15% plus inflation, they can lose it. Or if a carrier withdraws those policies from the marketplace and no longer offers that product anymore, then obviously that grandfathered status will go away. Grandfathered plans are exempt from a majority of the reforms, but they must comply with the prohibition on lifetime and annual limits for essential benefits. So that list of 10 benefits there, whether you're grandfathered or not, you can no longer have annual caps on those essential benefits, annual or lifetime caps. You do have to provide coverage for dependents under age 26. The network of providers will be much more narrow. So that's something when you look for health insurance, you're going to want to keep an eye on to make sure your providers are in that network. And also there are 8 territories now in New York for the regional rating. I don't know if you can see this, but those are the standard plan designs that are going to be offered on both the individual and small group exchange. And I put a little star over the silver plan because all the subsidies are based off the cost of the silver plan, and this will be the most common plan that people have. The deductible there, if you can't see it, is a $2,000 individual deductible, maximum out-of-pocket $5,500. Inpatient co-pays will be $1,500 per admission. So it's the full range of plans. Platinum, $0 deductible, $2,000 out-of-pocket, and then the bronze plan is $3,000 deductible, $6,300 or $6,350 out-of-pocket. And then that catastrophic plan, which is for those under age 30 or those who have a financial hardship in terms of purchasing coverage, would have a $6,350 deductible, and that would also be their out-of-pocket maximum. On the individual exchange in Manhattan, these are the carriers that will be participating. Some of the bigger names are Empire, Blue Cross Blue Shield, Emblem, and UnitedHealthcare. The rest are some of the smaller plans that are out there, but they'll be in the exchange. So there'll be a choice of 9 different markets in Manhattan. As I mentioned earlier, October 1 is the open enrollment date. That's when it starts. Final plan designs on and off market have not, for the most part, been announced. Rates have not been announced. You can see some basic rates in the small employer marketplace. On the exchange, you can see some basic rates on the individual market on exchange right now if you go to New York State's website. And New York really is probably ahead of most other states in terms of being ready to open their doors on October 1. I wouldn't recommend wanting to be there on October 1. I think you'll see a lot of the web-based interaction being less than satisfying. I think the traffic will be fairly heavy. I think it'll be tough getting through. It'll be tough with the phones. You'll see long wait times. Things will be crashing, and it's not like shopping at Macy's on Black Friday. You don't have to be first in line. Coverage is not going to start until January 1st anyway, so I'd recommend you probably wait until later in October. Excuse me. Wait till later in October when things settle down a little bit before you start your shopping experience there. The open enrollment starts 10/1, ends March 31, so they knew it was going to be a chaotic time, so they had the open enrollment extend for 6 months this year. If you do want the 1/1 effective date, you're really going to have your app in by mid-December, and then it'll be first of the following month after that. So you do have a little bit of time there. And then during the year, if you lose coverage through your employer or you have other qualifying events, you'll be able to sign up for the health insurance exchange at that time. Next open enrollment next year will be in October, and it'll run through December, so it'll be a much shorter window. They're not going to allow as much time as they did this year. And if you're an employer group, you'll be able to enroll anytime during the year with your group, so that's not going to be an issue. Premium tax credits. This is going to be a sliding scale of tax credits that are going to be paid on your behalf directly to the insurance company to offset the cost of your insurance. So it'll be based on second lowest silver plan cost in your area. And if your household income is anywhere between 133% and 400% of the federal poverty level, you'll qualify for subsidy in all likelihood. And that, for an individual this year, is $45,960, and for a family of four, $94,200. So it does cover a wide range, and I'll show you some examples of subsidies in a moment. If your income is less than 250% of the federal poverty level, you'll also qualify for some benefit subsidies. So if a plan had a $30 copay, it may only be a $15 copay for you. So that'll be available as well. And then when you take the tax credit, you have an option of taking all of it or part of it. Most individuals will take all of it to defray the cost of health insurance right at that moment, but you could also take part of it and then claim the rest of it on your tax return in 2015 for 2014. Eligibility, if you currently have affordable coverage through an employer and it provides minimum value, you're not going to be eligible for a subsidy through the exchange. And you must also be a U.S. citizen or legal resident to qualify. And if you want to check out, sample subsidies based on your family setting, you can go on to the subsidy estimator on the New York State of Health.newyork.gov premium estimator website and just plug in the variables and get it. It's fairly accurate. It's not totally accurate, and again, it's an estimator. And you really want to go through that estimation process up front, because when you actually do apply, what will happen is you'll have to go on the government site and input your actual financial information, and they'll do a lot of there'll be a lot of cross-checking on the data you put in, and it has to be legitimate data that you put in when you actually do qualify, because they do check against your tax returns to validate those numbers. And then in order to go through that process, it'll take about a half hour of your time to input a lot of data and get feedback from the exchanges. But to get a quick estimate, the subsidy estimators are pretty good. In this example that I've got here, basically, based on the level of federal poverty level that you meet, the premium you pay is capped. So that if you're, in this example, a married couple with 2 children, family income at $47,100 annually, you'd be at the 200% federal poverty level. The annual premium for the second lowest cost silver plan in New York is about $10,000 a year. The tax credit is going to be $10,000 minus that 6.3% of your income. So if you look at the chart, you see the 200 to 250 federal poverty level. Your premium can't exceed 6.3%. So that leaves you with a premium tax credit of $7,000, and the most you'll pay for your silver plan is $2,928. So the credits are fairly significant in a lot of cases, and will get people into the health insurance marketplace for the first time. Just an example for somebody, this is from the subsidy calculator on the New York site. One adult making $40,000 a year, they're at the 348% federal poverty level. Their subsidy is going to be $48. And then based on the plans here in Manhattan, you can see an estimated premium cost ranging anywhere from $310 to $593. In this example, with two adults, an individual and spouse making that same $40,000, they're at the 257% federal poverty level. The estimated subsidy would be about $454 a month. So that'll help reduce the cost. In this example, the two adults, one child between 19 and 25, one child under 19 with a $50,000 income, they're at 322% of the federal poverty level. And their subsidy will be about $645 a month. So it really drops down the cost of coverage and makes it a little more affordable. And this final example is just somebody who exceeds that $95,000 figure, and you can see there's no subsidy here at all. And the rates range anywhere from $1,000 to $1,800. In terms of who's going to be there to help you navigate through this, well, they have a navigator. And they have in-person assisters, and they have agents and brokers. So agents and brokers will be able to help sell individual products on and off the exchange, of course, and on the shop exchange as well. They'll earn commissions, and one of the things the exchanges were very smart about was that they want to make sure they don't have adverse selection. So the fees or commissions that are paid to agents and brokers in the exchange are identical outside the exchange. So it's the same level playing field. If you offer a product in the exchange, the carrier must offer the identical product outside the exchange. So there's no selection issue there too. In years past, when a lot of these things were done, they tried to save money on different things. So they said, let's carve out agent and broker commissions in the exchange, and we'll keep them out of the exchange. Well, obviously, agents and brokers didn't place business in the exchange because they didn't get paid. So what's happening now is it's all equal in and out of the exchange. The networks will be the same when they, for the exchange plans, when they offer them outside the exchange as well. They'll be able to offer a broader range of plans outside the exchange, but anything in the exchange has to be offered outside the exchange on the same terms and conditions. Navigators, in-person assisters are not allowed to help you select a plan. They're allowed to provide guidance and direction in terms of how to go through the process and how to fill out the paperwork, but they can't help you select a plan because they're not licensed. And that's one issue, and now there's a lot of discussion about security. If you go through a licensing process, you've got to comply with certain privacy requirements in your relationship with insurance companies, and as a navigator and an in-person assister, you don't have that same compliance issue, so there's a lot of debate going on that issue. But you'll be able to have access to a lot of support and help, because this is going to be very, very confusing for a number of people. We're going to talk about small business, and I'm going to bring Greg up for that.
Thank you, Roy. As Roy had mentioned earlier, my name is Gregory TROTTA, and I'm a consultant with UnitedHealthcare. I'm going to talk to you today a little bit about the shop exchange and small business, both on and off the exchange. So the shop exchange, similar to the individual exchange, is going to have metallic tier levels that all plans are going to have to comply with. So you're going to have your platinum level plans, your gold level plans, your silver level plans, and your bronze level plans. As Roy had mentioned, the benefits associated with those plans are going to differ by platinum level. So again, for example, the platinum plan, the insurance carrier is going to pay 90% of the costs, and the member is going to pay 10% of the costs. And it varies as you go down the metallic levels. So they're all qualified health plans. We heard a lot about minimum coverage, minimum value coverage. Any plan that you purchase through either the shop or the individual exchange, and all UnitedHealthcare plans off exchange as well, are going to meet minimum value coverage. So that's 60% actuarial value. So everything is going to be a bronze plan or above. So for compliance purposes, you'll be all set there. In the exchange, carriers are going to have basically about one plan per metallic level. UnitedHealthcare is actually going to have two in the platinum level because we offer out-of-network benefits off exchange, so we're mandated to offer out-of-network benefits on exchange. So we're going to have one plan in platinum, two in platinum, one in gold, one in silver, and one in bronze. And other carriers are going to do the same. These plans are standard plans, meaning that the benefits across all the carriers in each different metallic level are going to be the same. So a platinum plan with UnitedHealthcare and a platinum plan with freelancers is going to have the same exact copays, deductible limits, and things like that. The only things that are going to vary are price and network and things like that. So benefits are not going to vary, but your network with one carrier could vary greatly to another carrier. So you may not have the same doctors and hospitals and physicians with one carrier as you do with another. Also, alternative benefits and wellness programs, so things like acupuncture, gym reimbursement, things like that, those are going to vary by carrier because they're not essential health benefits, they're not mandated benefits. Also product types, you might see one carrier offering an HMO, another carrier offering an EPO, things like that. So you're going to see variations like that, but benefits are going to be the same. So your copays, what you pay to go to the hospital, that's going to be the same on the platinum level in the exchange with any type of carrier. And as Roy had mentioned earlier, any plan design offered on exchange will be offered off exchange as well. So if you work with a broker, you could go direct to the carrier as well and get that same plan at the same price. So Roy had spoken a little bit about the individual tax credit. There's also tax credits available via the shop exchange, and it's available to small businesses. There are certain requirements that have to be met in order to qualify for these tax credits. You have to be providing at least 50% of the cost of health care for the employees. Also, you have to have less than 25 full-time employees, and this excludes owners and family members. So say you and your spouse own a company and you have 25 other employees, that's okay because you're excluding you and your spouse as owners or your spouse as an employee on taxes. Also, you have to be paying annual wages of less than $50,000 per full-time employee. Now that's an average. So if you have one employee that makes $70,000 and another employee that makes $25,000, as long as you average them, they have to be less than $50,000 per employee. And again, this actually excludes any type of ownership wages or anything like that. So this is wages for your employees, not yourself. So how much can you get? What is the tax credit going to be? So for employers with 10 or less full-time employees and average annual wages below $25,000 and you're a for-profit company, you're going to get 50% of the employer contribution for the health plan. For tax-exempt employers, you're going to get 35% of the employer contribution. So these are the standard plan designs that Roy had went over in the individual exchange. So on the shop exchange, you're going to see all these metallic levels and the same plan design. So as we mentioned, we'll go through an example with the platinum plan. So a PCP copay on a platinum plan is going to be $15. A specialist copay is going to be $35. Now again, this is the same across all plans in the shop exchange. So whether again you have UnitedHealthcare or you have freelancers, you're going to be paying the same copay for an on-exchange shop plan. So this kind of just standardizes the process, makes it a little easier when comparing benefits and carriers, because you know that you're going to get the same plan design across all carriers. Again, the only things differing are going to be price and network and things like that. So who's going to be in the shop exchange? The individual exchange, we saw many more carriers. It was very robust. There was a lot of choice. The shop exchange is a bit more limited. There's actually only going to be 3 competitors in the shop exchange. You're going to have Metro Plus Health Plan, Health Republic, which is also known as Freelancers, and Oxford UnitedHealthcare. So these are the different carriers and the different plan designs that each carrier is going to be offering. As you can see, Oxford is going to be offering a PPO plan and an EPO on the platinum level, and then also on the silver, and in the bronze and gold, we're going to be offering EPO plans. This is an example of premiums for the shop exchange. So for a Manhattan-based group on a silver level plan, the employee-only premium is going to be $554 for an Oxford plan, for a Metro Plus around $387, and for Health Republic $408. For an employee family, so a family plan, the prices differ, obviously, because we could rate based on coverage level. Oxford EPO is going to be $1,580, the Metro Plus $1,103, and the Health Republic $1,164. And all these rates are based on the Department of Financial Services that released these rates. So, shop exchange, what's the benefits? Well, again, as we heard earlier, there's the standardization of the shopping process. So you could go to the shop exchange and you know that the benefits across all carriers are going to work the same. You, as an employer, you could go to the shop exchange and pick a freelancer's plan or a Health Republic plan and an Oxford plan, so you could have both plans, different plans along coverage levels. So say you want 3 silver plans, you could do that on the shop exchange. Whereas when you go off exchange, certain carriers have underwriting guidelines and plan limits and limits on other carriers and things like that. So this just gives you kind of a way to shop across all carriers and all metallic levels seamlessly. So it's also one bill. They consolidate the billing. So you're not paying each individual carrier for whatever plans you have. You're paying the exchange, and the money gets remitted to each individual carrier. There's no minimum contribution levels. There's no participation standards. For group plans off exchange, typically in the past there have been participation, meaning that we need a certain percentage of the group to join the plan in order for you to be able to buy the plan. In the shop exchange, there's no participation requirements. So you could have 2 out of 30 employees purchasing the coverage, and you could buy it through the shop exchange. So let's talk a little bit about off exchange. So we saw the advantages of going on exchange. Why would you go off exchange? Well, as we saw, for UnitedHealthcare, for example, they're only offering 6 plans on exchange. Off exchange, you're going to see carriers with much broader product portfolios. So off exchange, we're going to have the 6 plans we offer in the exchange, and additionally, we're going to have a large majority more plans in the platinum, gold, silver, and bronze level. Now, today, when you purchase health insurance, you never heard of platinum, bronze, silver, gold, none of that before. We actually are, and most carriers are, revamping our product portfolio to include all plans are now going to be based on metallic level when you're shopping both on and off of the exchange. Also, there's a greater selection. So off exchange, you're going to have more plan designs to choose from, more price ranges to choose from, different networks to choose from. So that's another benefit of going off exchange. On exchange products, we're going to have them off exchange as well. And again, the plan designs are going to be the same and the benefits are going to be the same. Sole proprietors. So sole proprietors were considered a group eligible for guaranteed issue coverage as a group of 2 or more. So if you had a spouse as an employee or with 2 owners, you could still purchase group coverage. Now, under the Affordable Care Act, this has changed now. Sole proprietors are now considered individuals if there are 2-person groups. So say you and your spouse own a company, or you own a company and your spouse is on your payroll, and that's all the employees you have. You're no longer considered a group under the Affordable Care Act. You're now considered an individual, and you would have to go to the individual market to purchase coverage. Existing small employer groups with 1 non-spouse employee will be offered individual coverage upon renewal. So if you're currently in a small group plan and that's your current setup, when you renew, you're no longer going to be offered a small group plan, you're going to be offered an individual plan. So this is the notice that Roy was speaking about earlier. Employers, by October 1st, have to give their employees a notice about the exchanges. So all employers are subject to this requirement if you have at least 1 employee and gross annual sales in excess of $500,000 per year. Again, this has to be distributed to your employees no later than October 1st, and either at the time of hire for any new employees or within 14 days of their hire for new employees. So there's basically 2 different types of notices. If you're an employer that provides coverage, you're going to give 1 type of notice, and if you're an employer that does not provide coverage, you give a separate notice. Basically, you have to provide this to your full-time employees, union employees, and employees in the waiting period. This is just letting them know about the exchange, about the credits, and whether they may be able to get more information and see if they qualify to participate in the exchange on an individual basis. I'm going to hand it over to Dan. Thank you.
Good morning, everybody. As Roy said, my name is Dan CORR. I'm a consultant with Mercer, and I specifically work in the middle market segment and help clients to really understand how they can be compliant with the complexities of the ACA going forward. The issue that I think all employers have right now is that we thought that there were some pretty hard lines drawn in the sand, but we're being forced to deal with a hurry-up-and-wait approach because we don't have an awful lot of guidance on true compliance for a lot of the components of the Act. But also when we get to the point where we're ready to go forward with complying with the Act, that the dates have been pushed off. So right now, I offer a perspective on some of the challenges or issues for employers, and for the purposes of this discussion, it will be for employers with 50 or more full-time employees, but this is where we are right now. We can expect further guidance as we go forward. So what I'd like to do is really just touch on where we are now as far as compliance with the Act, and then what is going to be taking place in 2014, 2015, 2018, which is the biggest concern, I think, for employers, and then some of the strategies that are being employed to address this going forward. Because I do think that what the Act has done ultimately, besides providing access to health care for anywhere between 30 and 40 million Americans, it really has changed the conversation about the design, delivery, and funding of health care benefits in general for employers. So where we are right now, as of 2013, any employer who had a flexible spending account is looking at a $2,500 contribution cap. Initially, that was unlimited. It was limited to $2,500 as of 2013. There are new taxes that are in place now for high-income households. That would be an additional 0.9% increase in Medicare payroll tax on wages exceeding $200,000 on the individual side and $250,000 for couples. There's an additional tax on medical devices that is tied to both insured and self-funded programs going forward. That is a 2.3% additional tax on medical devices. There is a fee on group health plans to fund Patient-Centered Outcomes Research Institute, or CORR. Really what it is, it's a tax that used to fund federal research on comparative effectiveness research, trying to get to the point where we're running a much more efficient healthcare system, and it's really more of an outcomes-based approach to healthcare. So there's additional taxes that are part of healthcare programs today. Health plan standards beginning in 2014. This is one of the things that hasn't been pushed off. As of 2014, all employer plans must provide coverage for dependent children up to age 26, regardless of whether they had access to other employer coverage, which is really interesting when you think about it, because let's say your child is just getting out of school and they have coverage under their employer's plan, you can still have them as dependent on your plan. So employers are now going to, there's a dual role for health care coverage. One, if an employee, a dependent has coverage under their own employer, they still are considered eligible under the parent's plan. So that's not going to change. That's going to change. There's no pre-existing condition exclusions in the plans, so it can't be underwritten for pre-existing condition exclusions. There's no waiting periods to exceed 90 days, similar to the small group limitations. There are no annual dollar limits on essential benefits. This has become an issue for employers that have medical programs that have their dental plans tied to the medical programs. Preventive pediatric dental coverage is considered an essential health benefit, but any dental plan has a limitation on what the annual benefits will be. So that becomes an issue on how you're going to deal with the plan design going forward, because as of 2014, essential health benefits will have no annual dollar limits. There is the Medicaid expansion as of 2014. This will allow states to actually expand Medicaid from 100% of the federal poverty level, as we were mentioning before, up to 133% of the federal poverty level. So for employers with lower income employees, they now have a decision as to whether or not to actually provide coverage, because if they've got a significant number of employees that fall below 133% of the federal poverty level, they would be able to access coverage through the exchange as opposed to the employer coverage. There's an increase in the wellness incentive limit to 30%. Employers now can create incentives for employees to participate in a wellness program and have a 30% incentive, up from 20% of the total cost of the coverage. So again, it affects the way that we're designing our programs going forward. or considering designing our programs going forward. There's a temporary reinsurance fees are going to be in effect for 2014. And these insurance fees, just as 1/1 for the fully insured marketplace, we're right in the thick of it now, negotiating final rates for 1/1. We've had to approach it from two different ways. One is to negotiate the actual renewal itself based on the experience and the demographics and the risk profile of the group, but there's also the ACA fees that are attached to it as well. So for all of our cases renewing on 1/1, there's an additional 3 to 4% fee that is attached to the cost of healthcare, to providing healthcare for 2014. So costs are going up, folks. Whether it's fully insured, whether it's self-funded, there's an additional 3 or 4% that's going to be attached to the fees to the premium going forward to help fund healthcare reform. And then this, we have an unclear effective date here. For employers with more than 200 employees, we have to set up a default plan, meaning that any employee who's eligible for health care coverage is automatically going to be enrolled in a default plan. We don't know exactly when that's going to happen, but that's the way that they're going to go forward with ensuring that employers are doing all that they can to assist employees in having access to health care coverage if they're eligible for it through the employer plan. Now, the shared responsibility, I'm sure you've all heard about this one, but it's been delayed until 2015. It really impacts only large employers, and those are employers with at least 50 full-time employee equivalents in the previous calendar year. In this instance, they must offer the minimum essential coverage to substantially all 95% of full-time employees constitutes substantially all. And a full-time employee is any employee who works on average 30 or more hours a week. They must offer full-time employees and their dependent children up to age 26 coverage, but what's interesting here, they've chosen to exclude spouses and domestic partners. So you're not, as an employer, you're not required to provide coverage for a spouse or a domestic partner. Not only do you have to have a minimum essential coverage plan in place, but you have to have a value of at least 60% that is considered affordable. Right? And we'll get into a slide that'll talk about the affordability component of this one. But if you're going to provide coverage and you want to look and not be subject to penalties going forward, as of 2015, you've got to have a plan that provides at least the minimum value and is considered affordable to the employees. If you're not providing a minimum essential coverage to substantially all, you face a penalty of $2,000 multiplied by the number of full-time employees, not counting the first 30 full-time employees. So one of the strategies then, that we've been talking about is, hey, Dan, is this my ability to get out of the healthcare business? What does this really mean? Can I just decide not to provide coverage to any of my employees and just pay the penalty? That is a strategy that does exist. You would be subject to the $2,000 penalty, not counting the first 30, and you can just push all the employees out to the exchange. The problem there is, employee benefits. Why do we even have employee benefits? That recruitment, retention, motivation component is now excluded, and for a lot of employers, they want to be considered an employer of choice, and if they're not providing employee benefits, then this puts them at a disadvantage to recruit and retain the right folks that are going to assist them in achieving your organizational objectives. If you're not offering at least an affordable program, the penalty is $3,000 for each employee receiving tax-subsidized benefits. So there are two ways of looking at that one. If you choose not to provide benefits, it's $2,000 minus the first 30, or it is a $3,000 penalty if you don't structure the contributions in a way that is considered affordable. What is the affordability test? Hey, the employer is required a contribution on self-only coverage, right? This is the safe harbor. The coverage cannot exceed 9.5%. I think we touched on this one. But the federal poverty level, see, here's the thing. With the federal poverty level, the expansion of Medicaid, states have the option to either expand Medicaid or not. So employers in multiple states now have an issue with determining what is going to be considered affordable based on whether or not the state where the employee resides has accepted the expansion of Medicaid or not. So for this, in this example, the state has not. So 100% of the federal poverty level is expected to be $11,835. So the maximum that you would be able to charge on a minimum essential value plan would be $93 a month. And the way that they get at that, if you've got an employee that's making basically $7.59 an hour, multiplied by 30, multiplied by 52, that's how they're arriving at the 11,835. So that person would be maxed out, is actually at the 100% of the federal poverty level, so the maximum contribution would be $83. What we've been seeing some employers do as they look forward to this is basically taking the lowest compensated employee and just working off of 9.5% of that salary. So if an employee is making $40,000, that the maximum contribution for the lowest plan that they're going to offer is going to be no more than 9.5% of that salary. The minimum value plan, we touched on this already. It's really, that 60-40 split. The actuarial value has to be a 60-40 where the plan is actually paying 60% and the employee is paying 40. It's not really that because there is a stop-loss cap to that. There's always going to be an out-of-pocket maximum. But I think what's shocked a lot of folks, especially here in the Northeast, where we're still kind of tied to a copay environment, it's taken a while for us to really introduce deductibles and coinsurance, both in and out of network. If you look at the proposed plan design based on safe harbors, you can have a $3,500 medical and drug deductible, meaning that that's going to be your out-of-pocket cost before the insurance company is going to pick up anything. Outside of your preventative care benefits, which will always be covered at 100%. Another example is $4,500 and a 70% cost sharing and the $6,400 out-of-pocket limit. Another one is the $3,500 medical deductible, 60% planned medical expense cost sharing, 75% drug sharing. So there are options out there, but a lot of really what was shocking to a lot of clients is that, yeah, we are pushing a lot of the first dollar costs onto the employees, where in the Northeast we really haven't done that as a regular cost shift or renewal mitigation strategy. So the safe harbors, right, for this on the shared responsibility, on that eligibility, the 30-hour work week has become an issue. And I guess it really can apply to law firms as well, too. If you've got part-time paralegals that are working on cases and called up on an as-needed basis, if you've got a large case where now a part-time person is going to be working more than the 30 hours a week, now we got an issue. Now we got to manage that, and how are we going to do that? What a lot of employers, not just law firms, but specifically in the hospitality industry and higher ed, adjunct professors, there's always been an issue. How many hours can you say that an adjunct professor actually works? And the argument will be it'll be much more than 30 hours a week. But what are we doing now to actually manage to that 30-hour work week? There is the option of choosing a look-back measurement period of anywhere from 3 to 12 months to look at the average number of hours worked per week during that work week, during that period, and then at that point determine whether or not that person's eligible for benefits. There's a more sophisticated model that we're using to help employers determine what really constitutes a full-time employee. But this is something that has come up for a lot of employers as they look to make sure that employees who are truly on part-time status remain on part-time status, because once they're eligible for benefits, they have to be offered the benefits. Okay, and there are additional employer reporting requirements that are coming down for 2015, and that is really just to ensure that the regulatory agencies are aware of your practices on employment and eligibility for the employees who may be eligible for the exchange or may not be eligible for the exchange. And this is probably the biggest cause of concern, I think specifically for employers in the Northeast, where it is much more expensive to access coverage. There is an excise tax of 40%, the Cadillac tax really, on high-cost coverage, including medical, health FSA contributions, medical clinics, employee pre-tax, and employer contributions to HSAs. So the initial cap is set at 10,200 on the single side and 27,500 for the family. We're not sure that that's going to stay in place, but that's where the initial cap is. But the excise tax actually is for any amounts above those cap thresholds. I think I dare to say that for a huge portion of employers in the Northeast, or at least New York City, mid-sized employers, they are just about at the cap. And if we project that out till 2018, we're looking at some pretty significant liabilities, either on a fully insured or a self-funded basis, if they don't make the appropriate plan design changes now to really address the cost going forward. The way it's going to happen is if you're a fully insured program, there's going to be an additional 40%. The plan will be underwritten, and there will be an additional 40% that will be a line item to say Cadillac tax, high cost tax, excise tax liability, and that's what you're going to be forced to pay. For self-funded folks, it's the TPA that's going to be responsible for it, and the employers ultimately will be responsible for the tax on the HSA contributions. Excuse me. So that's coming down the pike in 2018. But I think that for most folks, knowing that that is out there and some of the projections that we're using don't just look at 2018, but we look at 2020, 2025, that I don't think that there's an employer out there that is saying that this is a sustainable trend. That if we look at not just healthcare costs and the increases that are coming by way of utilization and experience, additional taxes through healthcare reform, and the excise tax, that there needs to be a different way of looking at benefit programs going forward. So what to prepare for? Design and marketplace changes. We're seeing a lot of employers that, are really, at one point took a wait and see attitude. The idea that healthcare reform is going to be repealed and we're going to go back to the old days, I don't think there's anybody that believes that there's going to be a full repeal. There are challenges to it, but whether the horse has left the barn, the train has left the station, there are components of that that are here to stay, and going forward, we're going to need to address that. The enrollment changes, what does this do to employers that now have a 30-hour eligibility? There's the individual mandate, so people who might not have chosen to enroll in the plan now are going to be enrolling on the plan. There's the Medicaid expansion, there's the auto enrollment, the additional fees, and then the employer mandate all have a direct impact on hard and soft dollar costs for the administration of the program going forward. So it's forcing employers to look at things differently. And in looking at things differently, one thing that has come up is defined contribution. One of, as I said before, the healthcare reform has radically changed the way that we think about healthcare benefits in general, specifically, but employee benefit programs in general, in the way that we design, that we fund, and we deliver these programs, and really what is the intent of the benefit programs. Defined contribution really came about in a desperate attempt to try and manage healthcare costs. If you're a CFO on the finance side, how can I manage double-digit increases every year? What is it? I can't just increase the cost for the widget by X percentage because my compensation costs, and I'm talking about benefits as part of total compensation, my compensation costs are increasing. So the emerging strategy of defined contribution looks at the way on the pension side, defined benefit and defined contribution evolved too, where employers were providing a traditional benefit plan. They migrated more to a defined contribution plan. The defined contribution approach is something that is mirrors much more closely the past cafeteria plan approach, where I'm just going to set aside X number of dollars a year per employee, X number of dollars per family, and then the employee is actually going to make the decisions on what plans are good for them. So there is the CORR buy-up strategy that's out there, flat dollar subsidy, where I'm just going to say I'm giving nothing more than $10,000 per employee, or there's going to be a fixed employer increase where I'm going to manage my costs by looking at nothing other than CPI going forward. It's going to be, I really can only manage a 4% a year, so that's what I'm going to manage on my benefit programs as well too. And it's resetting the benefit value, and there is a a sincere effort from most employers to help employees understand that the benefits program that they have in place right now is something that they should value as an important part of their total compensation. And because of that, they should have a vested interest in helping the employer to maintain a quality, comprehensive healthcare program. So the idea of health improvement, wellness programs is being introduced in just about every single program, either from the carrier resource side or from the investments that are being made from the employers to help employees get healthy. It doesn't really reflect an immediate impact, but it's more of a long-term cultural change in the expectation of employees to assist in controlling costs going forward by maintaining a healthier lifestyle. So what we have been seeing, and Mercer is also a big part of this, is the investments and the philosophy behind the public exchanges. What can we do to provide that sort of choice, that sort of option to employers going forward, right? So the private exchange, it's a much more flexible approach where you're actually controlling what it is that's going to be available for the employees on an exchange basis. So we're looking at the defined contribution approach where an employee would have an account-based plan where X number of dollars would be deposited into the account, but now the employee would have the option to choose what benefits are right for them. And you know, you might have heard this, but it's more of the Amazon.com approach to employee benefit programs. There are a lot of assumptions that employers are making about what really works for their employees. But as you know, employees are at different stages of their life. Certain things are important to employees at different stages of their life. The disposable income is different for employees at different stages of their life. So why are we making these broad-brushed assumptions about what truly works for employees? Why don't we just provide them with the tools that will allow them to make the informed decisions, but also allow them to have the products that will fit their needs given their lifestyle choices? So it's really, it's similar to a lot of the decisions that employers are forced to make right now, is whether it's a single or multi-carrier approach, fully insured or self-funded, medical only or a full benefits exchange, active and or retirees, DB and or DC options. So that the idea of the federal exchange or the investments that were made in the infrastructure for the public exchanges, we've been able to access a lot of what has already been done on that side to partner with the carriers to provide an exchange approach for private employers as well too. And this is Mercer's Marketplace Exchange, and the way to think of it is what we've done is we've partnered with vendors and carriers on the medical side, the dental side, ancillary, whether they're sponsored or voluntary, and then we've bundled that with a benefits administration capability. The problem with a true cafeteria benefit for mid-sized employers is that the technology really didn't exist. It was just a very inefficient program. We weren't able to use an outsourced benefits administration model to administer the program. So now there's a benefits platform that will allow that to happen. And then the consumer experience, when I was saying that the assumptions that employers are making, we're taking away a lot of these assumptions, and we're going to design a program that we believe can capture all the needs of the various employees that we have in our population. So the employer contribution can be changed, the consumer enrollment portal, the decision tools, the decision support that's out there, all that stuff now can be there through the use of technology, which I think is where a lot of people are expecting it to be these days, quite honestly. And then you've got decisions tools and our call center. It's just a radically different way of looking at benefit programs, where it's taken out of the HR department and it's pushed out into the area of a marketplace exchange. And the objectives here, you know, reduce cost, obviously. I don't think there's a single employer that's considering this without taking a look at how this is going to impact their bottom line. Promote flexible choice, you know, looking to engage employees. You know, we want to be an employer of choice. How do we make sure that employees understand the investment that's being made in the employer-employee relationship when it comes to benefits? Improve administration and receive exceptional value. That's really what the value proposition for the Mercer marketplace, but any marketplace, you'll be hearing the same thing. Benefit options, 20 types of benefits. There are core benefits, voluntary benefits, additional options. It really, what it does, it allows a mid-sized employer to have the benefits of an administration platform that prior to this was only available in the large employer marketplace. And in preparing for 2014, there's lots to consider and do ultimately, right? Employee communications, just with the idea of the exchange coming out, and then the DOL, even this past Friday, issued the FAQ that employers who do not provide, there are going to be no penalties or fines associated with not providing the exchange notice by October 1st. Right? But that doesn't mean that in the HR offices, your offices, you are not going to be inundated with folks who've got a lot of confusion about what's going on within the exchange marketplace, because these are plans that are going to be sold. So if you haven't seen it already, there's going to be an awful lot of direct-to-consumer advertising on these, and they're going to be told that this is what they have access to these plans, but they don't really need access to that plan because they've got access to their employer plans. So there are going to be a lot of questions that are going to be bubbling up about what are really my options and what should I be doing. So there are employee communication issues that are out there. There are data requirements. I really don't know how a lot of folks are really going to be managing this efficiently and effectively, but tracking all workers, erroneous receipt of federal tax subsidies for exchange coverage. You can go to the exchange and apply for it, and there's no real support or no real check, as I understand it now, whether or not you have access to an employer plan. But if you do, you would not be eligible for the subsidy. So how is that going to be handled? Coverage reporting and disclosure. Multi-state employers, as I was saying, the expansion of Medicaid is going to create a huge issue on the shared mandate. And then the system requirements. What is it we need to do to increase the access to data on our internal systems too. So these are, in general, a lot of the issues that employers in the mid-market or employers with over 50 lives are trying to address and try to understand as we go forward.
Thank you, Dan. At this point, we'd like to open it up for questions. There are microphones out in the audience, so just raise your hand, and there's a microphone over there. And somebody around? Okay. The mic's not, Allison? She's got. Okay, why don't you go ahead?
I'm sorry, this is an individual mandate question, and I'm sure it's totally simplified. But I heard you speak about access to network coverage in the various plans available under the individual mandate. Can I assume that out-of-network coverage, out-of-network physicians will also be covered by the insurance?
That'll depend on the plan design you select. There'll be different plans on exchange and off exchange. And
So we start with a non-exchange platinum plan. Would you expect access to out-of-network physicians?
some of the platinum plans have out-of-network access and some don't. It depends on the type of plan that's being offered on the platinum level. So it could be an EPO plan, which would not have out-of-network. It could be an HMO plan, which would not have out-of-network.
What's EPO?
EPO is exclusive provider network, and that's kind of like an HMO. It's just here's the fixed network that you can go see. If you don't see anybody in that exclusive network, you have no coverage outside. So it really depends on the plan design. You're looking for a PPO plan, which provides in and out of network benefits. So that would be your measure.
Letter before the P?
PPO, Preferred Provider
Thank you.
Organization. So that's if you're looking for the out-of-network benefit, that's the plan design you want to go to. The HMO and EPO are very restrictive networks. You can only go see in the network.
One short other question. how I saw your list of navigator, agent, et cetera, access to people who might be a guide. How do you find those people?
You'll be able to access those people through the state exchange website.
And
There'll
the
be a
name
list
of the
of
website?
the New York State of Health. Let's see, I think I've got the actual. www.newyorkstateofhealth.com.
Thank you.
Hi. My question is directed towards the distinction between sole proprietor individual plans or the individual exchange and the shop exchanges. I'm not sure I understood the clarification, the distinction between two people who are sole proprietors and two people who maybe, say, have a PC or an LLC. Could you just review that for us? That's question number one. And the question number two, which is directed to all three of you, is will you be making the slides from this excellent presentation available?
Sure. So the answer to number two is yes. We'll send them to the city bar, and the city bar will be able to go ahead and distribute those.
Terrific. Thank you. So, Mr.
As to your first question, so whether you're a PC and LLC, if you're a husband and wife company, you are not considered, and it's only the two of you and you have no other employees, you are not considered a small group anymore under the Affordable Care Act, so you cannot purchase small group coverage anymore, and you would be now open to the individual exchange or individual products off exchange.
So any PC, LLC, or sole proprietor with one or more non-family member employees would qualify for the shop exchange, or they could stay out of the exchange and continue with existing coverage.
No, you would not be able to stay out of the exchange and continue with existing coverage. So basically, if you're, a husband, wife, PC, LLC, what have you, you will be, upon your renewal, you're going to have to make an attestation stating that you're not one of those groups. And if you attest that you're not one of those groups, you could continue on with your coverage. But if you are one of those groups, you're going to be offered an individual product as opposed to a small group product.
Thank you.
You have to have a non-spouse employee on the W-2. That's going to be the key. If you don't have that, you're going to be considered an individual. Now, New York law previously said you're a small business and you can buy a small business product. And there's discussion right now with the Department of Financial Services to see if there's some way New York State can override the federal legislation to continue that. And we just don't know the outcome of that yet. But at the present time, you'll be considered an individual.
Thank you.
Hi, I wanted to ask about Healthy New York, which is a program in New York State of subsidized insurance for individuals and small businesses. There's an income cap, and it's designed to encourage, like the Affordable Care Act, to encourage individuals and small businesses who have not previously had insurance or provided insurance. So what is happening with it? Is it being replaced by this? Yes.
So Healthy New York, it's going to depend whether you're an individual or a group. Healthy New York group is going to be changed. So if you're in a Healthy New York group plan, at least with UnitedHealthcare Oxford, you're going to be mapped into an equivalent gold plan. So it is being continued. Healthy New York on the individual side, that is actually, you're going to be receiving notices and being sent to the New York Individual Exchange, where the subsidy and things like that are supposed to kind of work in the same manner as the Healthy New York program for individuals now.
Yeah, and if you're in a sole proprietor in the Healthy New York plan, you're going to be moved into the individual exchange. That's being discontinued at year end.
Okay, so it's still going to be called Healthy New York, but it's actually...
For the group plans, it's still going to be called Healthy New York. Individual, I believe they're doing away with it, and you're going to be sent to the exchange.
Thank you.
No problem.
Good morning, and thank you. How does this system change the reasonable and customary calculations that apply to everything, and that make sure that no matter how high your deductible is, that you have a really high deductible? That's my first question. My second is, if you have, regular insurance now, and you might have a catastrophic plan on top of that, does the Affordable Care Act change the availability of that catastrophic plan?
So I'll answer your first question first. So basically, you want to know,
I mean, if somebody's talking about you're going to get reimbursed 80% of what's reasonable and customary, assume that you're talking about in-network providers. The numbers are not 80% of anything. They're usually far less in reality.
so the way it works with in-network providers is that we have contracts with those providers. So we have a contract with, say, your physician, and we tell your physician for X, Y, and Z services, we're paying you this amount. So there is no usual and customary on in-network charges. When you go out of network, we don't have contracts with those providers, so we don't have a standard scale to, they could charge us $10,000, but we're not necessarily going to pay that. So we need something to base it off of. Now, in the small group marketplace, so individual and 2 to 50, the move over the years has been to a percentage of Medicare. And currently at UnitedHealthcare, we reimburse at 140% of Medicare. And that reimbursement rate, I would imagine, I don't have confirmation, is going to be staying the same. I don't see it moving to a usual and customary charge, which in all honesty tends to be a greater reimbursement for out-of-network services. But the market, the small group market in general, not just UnitedHealthcare, currently today reimburses on a percentage of Medicare.
So that's not going to change under the new act.
The new act did not regulate out-of-network reimbursement rate.
Okay.
Yeah, and with regard to excess, if you're looking at a catastrophic type plan, high deductible that sits on top of the medical, most of those have been discontinued or will be discontinued because they're not ACA compliant.
Okay.
So you may be hearing from your carrier about that.
And
Okay.
another thing I would caution on that note is, for compliance purposes, when you start adding benefits out, so say you get a UnitedHealthcare plan with an 80% actuarial value, when you start adding benefits on top of that, you have to be careful that you don't go into what we call the swimming lanes of actuarial values, because that becomes on the part of the employer to make sure they're compliant with actuarial values when they start adding things. So if you, say, add a benefit and it increases the actuarial value of your plan by 5% and you are at 80, so now you're at 85%, you're technically non-compliant with the law because you're in the swimming lane and you're not plus or minus 2 of the actuarial values.
Okay, thank you.
Yes.
I think you covered it in the, oh, I'm sorry. Sorry, go ahead. Okay. I think you covered it in the previous question, but this entire presentation was about 1 to 50, right?
Well,
This is everything.
this was everything, large group as well as small group.
Okay, great. Start off with the stupid question. Is there a requirement that an employer has to give a uniform healthcare plan to an entire workforce? So if I have 100, every single one has to have the same thing provided to them?
They don't have to have they have to have access to the same plan. So we can't structure it that only partners are going to have this plan, or only associates are going to have access to this plan. If you offer a plan, it must be accessible to all employees. So I guess the question is...
And then it's their option to
Correct,
choose
right,
which one they...
Right, and what is done at that point too is that the contributions are structured, whether they're salary-based or, can't find the word now, I'm sorry. Yeah, yeah, so we could structure the contributions so that it's more expensive for the higher compensated folks to pay that, or lower compensated employees have access to the baseline plan that is no more than the 9.5% of the lowest income earner at a firm. Then you would be fully compliant there.
Okay. And does that change at all when you have a portion of your workforce that's unionized?
Collective bargaining agreements, I really can't comment on that. I'm not an expert in that area. But I think that ultimately the CBA is going to govern what that group is going to be have access to. So I'm really not sure, to tell you the truth, though. But I know that it's dealt with differently, that unionized organizations, unionized groups have different rules according to the Act. And
So under the ACA, they're actually treated as if they are their own workforce. Is that what you're saying? So that the accessibility, the uniform accessibility does not apply to a unionized worker?
Correct, because I believe that the CBA would say that we have access to this plan, and this group is exclusively entitled to access to this plan.
Okay. Do you know of any places where you can get more guidance on collective bargaining and its interaction with the ACA?
Yeah, I can't tell you that one.
I'm not sure, to tell you the truth. I'm sure the DOL website will have.
Sorry? Okay. Future training. Okay. Thanks. I have another question. You spoke about the strategy of an employer to just pay the penalty and pass the cost on to their employees. And you spoke about you pay $2,000 per employee that you're not providing access to coverage for.
Correct.
And then you mentioned something about the minus the first 30.
That's correct. Right.
What was the minus the first 30?
Well, the penalty only applies to those beyond the first 30.
Beyond the first 30
30
people?
employees, right,
So if you
full-time
provide
employees.
health
So if you've got
coverage-
200 employees, then you'll only be paying the $2,000 penalty on 170 employees. If you've got 100 employees, you're only going to be paying the penalty on 70 employees.
So they just take out the first 30 from the penalty.
What if you have a workforce of 5 and then you
And it
pass
doesn't
on
apply.
You're not subject to
You're not subject.
that mandate.
You're not
That's for
subject
groups
to-
50 plus.
50 plus? Okay.
It's 50 or more full-time equivalent employees. So you can have a lot of part-timers, but there's a formula you have to go through and calculate, and you could put you over the 50 if you have, say, 40 full-time and, 30 part-time. Based on the number of hours, you could be in that 50-plus category. But that only applies for 50 or more. You don't have to worry about it if you have 5 employees. Not an issue.
All right, thank you.
Thank you. If I understood you correctly, the same policies that are offered on exchanges have to be offered off the exchange. Is that correct?
Yeah.
So what would be the advantage or disadvantage or the law with respect to where you would buy your policy? In other words, why would you buy it on the exchange? Just to get the subsidy?
So that's one of the benefits of buying on the exchange. Now, a benefit of going off exchange is, so basically whatever's offered on exchange must be offered off, but not vice versa. So outside of the exchange, you're going to see likely carriers are going to have a lot more products off exchange. So whereas we may have 3 EPO plans on the exchange, we could have 10 to 15 off the exchange.
But as to the policies that you would have, say, on the exchange and off the exchange, if it was the same policy, are they going to be priced the same, or do you price them differently?
They would be priced the same.
Priced the same. Second subject matter is prescription drugs, which I didn't hear much about. What does the Affordable Care Act require with respect to prescription drugs, and how does that also interact with deductibles? Because sometimes a policy will have deductibles, and in effect, basically, prescription drugs end up not being covered because the employee has to spend so much money towards the deductible that they end up paying for their own prescription drugs anyway.
So prescription drugs are an essential health benefit in the Affordable Care Act, so they must be offered on all plans now. So you will have a pharmacy benefit on every single plan now. Now, what you're referring to, it really about them, having to meet the deductible first. That depends on the plan design you choose. Typically, HSA plans have pharmacy. You have to meet the entire deductible
Right.
first before we start paying for your pharmacy that switches to co-pays or co-insurance, however your plan design is set up. That's really going to depend on your plan design. Now, naturally, because the benefit works like that, those plan designs tend to be cheaper than plans that have the pharmacy with just co-pays from the get-go. So it really depends on your purchasing decisions and the plan design that you select.
Did I understand you to say that the high deductible plans with
HSAs?
with HSAs are not going to be offered on the exchanges or not allowed?
It's not that they're not allowed. It's going to vary by carrier. The plan designs that the state had set up as the standard plans, they're not HSA plans. But off exchange, you could buy the HSA plans.
And one final question on that. Are the plans still allowed to make 3 tiers of drugs? They'll
So you're,
3 tiers of drugs and say, well, we're not going to cover this drug that your doctor prescribed. You'll have to take a different drug, which we think is cheaper, but may not be what the doctor wants.
again, that's going to depend on your carrier and their formulary. Different carriers have different formularies of different drugs that are included in Tier 1, Tier 2, Tier 3, also things known as specialty drugs. So that's really dependent upon which carrier you select and whether
So
or
the
not.
ACA doesn't address that?
No, what they address is that there has to be a certain drug in each category level. So say
Okay.
for blood pressure, as long as you cover a drug for blood pressure, you're compliant. But it doesn't say you have to cover Lipitor, or certain types of drugs. So as long as you have certain ones in each category, you're fine.
If you'll indulge me, one final question. A lot of members of the Bar Association who are small groups or who are sole proprietors, have coverage through the Bar Association. Now, that doesn't count as the type of employer coverage, does it, that precludes you from being eligible for the exchange, does it? Does that make sense?
So you're saying,
If you have access to employer coverage, you're not eligible for
No,
the exchange, correct?
so you either come to the Bar Association and you get your plan on a sole proprietor or a group basis. Now, if you're a small group, say you're a law firm of 5 attorneys, and you want to perhaps leave the Bar Association and go to the shop exchange, you're not considered group coverage. The Bar Association isn't offering you coverage as an employer.
Okay,
It's offering
that's
you
what-
coverage as an association.
Yeah.
Okay, thank you.
No problem.
Thanks. I had a question. Is the credit refundable credit? Is the credit refundable or non-refundable? And secondly, is there any provision, either state or federal, that provides assistance to families going through the health exchange since they're not receiving the credit until the 16 months after in the following year on their tax return? Is there any assistance with payment of premiums or any program if you got somebody, a family of 4 that's making $45,000 a year with $1,800 to $2,000 premium, if the bulk of the assistance is coming as a tax credit, is there any provision to assist them?
Yeah, I think if I understand your question correctly, that the tax credit is paid on your behalf directly to the carrier by the government. So you're not getting anything directly, and the accounting for it happens on your tax return in the following year. And that's going to be, I think there's going to be a couple of interesting things or flashpoints in the whole implementation of healthcare reform. I think on January 2nd, after everybody has signed up for their health insurance and now has a card on January 1, when they start calling the provider networks and trying to get appointments, I think you're going to see a big reaction from the population who now has health insurance for the first time, finding out that they have to wait months to get in to see a physician, because the networks are narrow. There's going to be an overwhelming number of people hitting the marketplace all at once, and access is going to be a problem. The second time I see another flashpoint is in April of 2015, when everybody files their income taxes, and all of a sudden the amount of money they said they earned to qualify for a subsidy doesn't match up with what they're filing for as a return, and the government's going to be asking for the payments back. And people will be shocked when they have to pay tax on the credits they've already gotten. But so that'll be an interesting dynamic in 2015. But I think in terms of right now, the tax credit that you say you're qualifying for based on income is going to be paid directly by the government to the carrier to offset that premium cost today. You can defer that and then work it out on your tax return in 2015.
Okay. I think that answers the question. Thanks.
Hi. I have a PC with a medical reimbursement plan, and I'm the only employee. Consequently, I deduct all of my health insurance premiums that I pay for my husband and me. Is that over to be replaced with this sliding scale of tax credits?
I would check with your CPA on that. Yeah. We don't give tax advice, so we've got to say that. But yeah, I mean, you're going to be an individual under ACA in 2014.
Thank you.
Sure.
Could you please clarify something that I think you discussed earlier? If an individual is under an individual plan through the city bar, starting January 1st, they're thrown into the exchange, or do they keep their policy?
The city bar program is up for renewal April 1, so nothing's going to be impacted until at least April 1. It's our understanding, the way the ACA works today, is that you as an individual, under New York state law, were given access to small group because the law permitted that when that program was established. And that was a great benefit for sole proprietors because they could get affordable coverage at group rates and group benefits. Under ACA, it takes a different interpretation of sole proprietors. And the way it's looking right now is that on April 1, 2014, you as a sole proprietor with no non-spouse W-2 employee would not be able to continue in the bar program, and we would have to investigate individual insurance for you. Guaranteed issue, all that, no pre-X or anything like that, but there might be a change on April 1. United is taking a look at, or is in discussions with the Department of Financial Services to see if there's some way we can fix that for the bar and other associations. And the association will be writing letters as well to help lobby that effort, and we don't know the answer to that, but based on ACA alone, it's an issue right now.
So in other words, the statement that if you like your insurance, you can keep it is a misrepresentation?
I would check with the president on that, but I would agree with that, yes.
Thank you.
Sure.
I'm a reasonably bright lawyer with no experience in this area. From today's session, I'm confused. I do not want to spend the time necessary to get to the point of sophistication that you guys have in this area that I have in the specialization that I'm in. If I want to hire someone to tell me what's the best thing for me to do, and you've explained that most of the people that you list there for assistance are not allowed to make a recommendation, who do I hire?
I would look for a good, I would look for a good agent or broker who you would rely on for your health insurance decisions today to give you the guidance and advice on whether or not you should be in the exchange, out of the exchange, and what your options are.
Would that be a person who's affiliated with a company? Like, I mean, I'm currently with UnitedHealthcare. Can I get some advice from that person that is going to be recommending something other than UnitedHealthcare?
Yeah, I think, I don't know how you're accessing UnitedHealthcare, but if it's through an agent or broker, that's the person you would want to start with and have that conversation with and say, tell me about this, tell me the pros, cons, the advantages, and then help me make decisions as to where I should go moving forward and get me the information I need to do this. You're absolutely right. It's, you know, the government figured it out right. They had a 6-month open enrollment. I mean, that's unheard of on any kind of program. Usually it's 30 days, 60 days, or something like that. Here it's 6 months because there's a lot going on. This is the most massive change since Medicare. And you've got so many different choices, so many different options. In other parts of the country, there are health plans have taken a decision to offer an early renewal in 2013, basically a second renewal on December 1st. So that you don't have to deal with any of this until next year when the dust settles. So that, you know, you may have had a renewal in May and they're letting you renew again in December, so you can lock in from December to December at your current benefits with a little bit of an increase in price from last April, just so you don't have to go through all this stuff right now. It's just chaotic. There's no doubt about it. And you know, that's why they're going to the navigators, the in-person assisters, enrollment counselors, agents, brokers. They need as many people in the process to explain it, because don't forget, the main impetus is to get people who have no insurance today insured. Well, if you have no insurance today, you're not generally knowledgeable about how that whole process works, what a copay is, what coinsurance is, what a deductible is, what a formulary is, et cetera. How are they going to figure it all out? Well, you need as many people out there as possible trying to guide and direct and educate and understand. So the outreach has got to be massive for this thing to work.
Okay, I hear you. Is there a way to get an independent advisor who's not affiliated with a major or with a?
Yeah, you know, again, if you're buying coverage through an agent or broker, I would talk to that agent or broker. They should be able to help provide that independent information and give you the guidance and then help you get placed with whatever.
So I'll
whatever
go
plan.
online and look for an independent broker.
Yeah, you know, if you don't have one, I would talk to your friends, neighbors, the city bar. You know, we're
I'm
sponsored
talking
by
to you.
the
I
city bar.
mean, you're a guy who could give me some advice.
Yeah, and my staff can do it as well. I mean, we do that with members of the city bar on all their insurance every day. So absolutely take advantage of it as a member.
Okay, thank you.
Sure.
Good morning.
Good morning.
I have an issue with EPO plan, which is basic plan, regarding diagnostic coverage. It's 500 per year, but you buy the plan and you pay a lot of money because, as you know, the provider, any provider you go to him or her, they ordered a lot of tests just in case they don't want to be, they want to be exact. So as if you buy this plan, EPO plan, but you end paying a lot of money. Just I want to ask, is the new affordable care plan is going to take into consideration the diagnostic coverage, which is 500, is extended to be more? Because when you buy the plan, this is affordable plan. It doesn't cover everything. You ended one visit, two visit, or do one scan or one blood work, and after that they told you your coverage is exceeded, and the insurance company does not pay for that. So what's the benefit of getting EPO plan if it doesn't cover the diagnostic coverage, or it doesn't help a lot, you ended to pay a lot of money?
So you're talking about an EPO plan?
Yeah, EPO plan.
So this is, I think, one of the things that would really vary depending on the type of plan you have. Some plans have richer benefits than others, meaning that for certain services, they charge you less than other plans. So I would take a specific look at that benefit, and then when you're going in to compare other plans on the exchange, off the exchange, or wherever, I would take a look at that specific. Now, are you talking about lab costs or MRIs?
Yeah, lab costs like blood work. You did one blood work, and you do one of the scans, like CAT scan or MRI, and you ended. They told you the insurance company you exceeded your coverage. We are not paying. And some providers they ask about a lot of invasive process, like they don't they don't diagnose you right away. They ask a lot of CAT scan, MRI for something simple.
Now,
what's the rules that governs also, my other question, governs the providers? Because when they saw that you have private plan, they ask a lot of invasive procedures.
To be quite frank, I don't think much governs the providers. The providers, you know, they bill and they test what they see fit against their best medical judgment. But now, the limits and things like that are a little what concerns me. Maybe I'll be here if you'd like to stay a little after. I don't know what company you have or whatever, but because the limits where you're saying that they're not paying after a certain dollar amount, I find that odd. So I will be here after to, if you want to get more specific with the questions, and I could try to assist you.
Yes, please. Thank you.
No problem.
My question is regarding penalties. I guess, how is it going to work? Is it every single year based on the price increase that you explained before? Or whom do you have to pay and when?
Are you talking about individual penalties or employer penalties?
Both, shop and individual plans.
So for the individual, you're going to be basically paying the IRS. For the first year, it's going to be either $95 per individual up to, I believe it's three individuals, or 1% of your annual income, whatever amount's greater. And I believe you'd be paying the IRS that amount of money. And for the employer mandate, If you're an employer with over 50 employees, which this provision is delayed until next year, and you don't offer, coverage that meets minimum value requirements and affordability requirements, depending on the which one it is and how you offer it, it's going to be a $2,000 or $3,000 penalty per employee over the 30 employee threshold.
And the IRS will issue a demand for payment.
Oh, I see. Okay. So at time of filing taxes, that's when all this gets paid.
Yes.
Okay. Thank you.
No problem.
I have a question. With respect to some employers who are making employees part-time in order to not cover them under health insurance, do you think that is this an effective strategy?
I would say it's based on the full-time equivalence. So it's not just kind of the line of, okay, you're full-time, you're part-time. You're also taking your part-time employees and you're adding their part-time hours up to, and then doing a calculation to get full-time equivalents. So it really depends. I don't personally see it as very extremely effective, but
It may have a significant financial impact for larger employers, but ultimately, at the end of the day, a CEO, CFO, they're going to be charged with doing what's right to fulfill the organizational objectives. So if we're managing to a 28 or a 30-hour work week and we can't maintain the appropriate employee population to help us achieve our organizational objectives, then it's not an appropriate strategy. But if you're dealing with a lot of unskilled or limited skilled employees in a wide open labor market, it may be an appropriate strategy.
Do you have to offer the full-time equivalent hours that you use coverage after you determine that you have to offer coverage?
Yes, you do.
You do, okay. And with the delayed effectiveness, are all the employer, let's say, mandates, or are they still in effect, or are they delayed as well? Or do you just have to do a good faith interpretation?
I believe everything is in place. They're just not going to be enforced. So the expectation is that you're going to be continuing this, but there's no enforcement. There are no penalties or fines that are going to be imposed for not doing it.
So if you don't comply, there's no...
Correct. There's no penalty.
You mentioned that there's an individual mandate exception for religion. Could you please describe that?
Yeah, I can't go into much detail on that other than for religious purposes, you can object and file it based on that. I can't give you the detail on it, but it's in the legislation.
As an individual sole proprietor shopping on the exchange, where do we look for the fine print? What is the formulary policy? Who are the providers? Are out-of-state emergencies covered? Those types of things are not currently covered in the matrices, which are themselves pretty hidden. So is there some place that you can recommend that we can really look for that fine print, or is this just something that we're going to have to task for each individual insurer?
So I'm not exactly sure how much information when you log onto the exchange that they're going to have readily available. They will obviously have the carrier names and plan designs on there, and I'm not sure if you're going to have to individually go to each carrier website or call each carrier to request that information. But I know for UnitedHealthcare, things like our formulary, you could access on our website without even being a member, and it's fairly easy, and you can browse all of our corporate and administrative and clinical policies on the website as well. So as you mentioned, out of various emergencies, you could see how that is covered on our website across all plans.
And the provider networks will be listed on the state exchanges, so you should be able to click right there and see who's the network on each of the different plans that are available. It's not there today. And, again, October 1's the rollout date, and, we'll see how close everybody gets.
Okay, thanks.
Are there any special rules or guidelines dealing with temporary staffing companies which may have, say, 80 individuals on their payroll, but maybe no more than, say, 25 working at a particular time?
I don't know that one.
Yeah, I can't answer that. Don't know.
Okay.
Sorry.
What will happen with plans that the state has in place, like Metro Health Plus, for people who don't qualify for Medicaid but have low income, like under, say, 300% FPL or 250?
Greg, do you know that one?
I'm going to be honest, I'm not 100% sure from what I believe. I think that those, if you're under, so it's basically going to be Medicaid or the individual exchange, and anything else is going to be done away with the exception of the Healthy New York group coverage. But on an individual basis, I believe that they're going to be pushed toward the individual exchange unless they're Medicaid eligible.
How will people be notified? Do you happen to know, will those, there's an enormous population of people who are on those. I mean, I think it's pretty big in particular communities. I'm just curious because I think there will be a lot of people who will need to help their employees understand how that works.
For UnitedHealthcare, our Healthy New York members and individual members, prior to terminating coverage, we send advance notice to the members. I believe it's 60 days prior to the termination date of their coverage.
And I happen to notice on the premium lists that UnitedHealthcare has a significantly higher premium. How is that accounted for? I know you talked about potentially networks, broader networks. Is that the case, or is United's price just 50% higher than everyone else's?
So it would depend on which segment you're looking at. So the individual, yes, we're priced significantly above the competition, and small group, we're rather competitive. Small group, again, it's our network. Our network is going to be by far the largest on those exchanges, so there's a value to that, and that costs more money, frankly. On the individual side, that's basically how our actuarials priced the business that they thought to be, for us not to lose money, essentially. I mean, they feel that the individual, based on our previous business, and that's just their thoughts and projections on how they feel it should be appropriately priced.
All right, it's 10:30. We need to wrap up. Thank you very much. Appreciate it. We'll be here to answer any of your questions and continuing as long as you need us here. Thank you.
Upstate, so I didn't